and thank you so much for joining us for this webinar on long-term DCB evidence for failing hemodialysis fistulas. Do we have a new standard of care? I'm Bart Dolmatch. I'm an interventional radiologist in Northern California, co-director of the CETA meeting and professor emeritus at University of Texas Southwestern Medical Center. I'm joined by a terrific faculty, including Andrew Holden, Director of Interventional Radiology at Auckland Hospital in New Zealand, Ari Kramer, Associate Professor of Surgery, Chairman of Vascular Access Department in Spartanburg Medical System in South Carolina, and Terry Litchfield, President of Access Solutions, Blanchardville, Wisconsin. Here are the faculty disclosures. This program is provided by HMP Education, an HMP global company, and it is supported by an educational grant from Medtronic. The learning objectives of this webinar are to interpret clinical evidence on the long-term effectiveness of drug-coated balloons, or DCBs, for hemodialysis fistulas, to understand how to prevent fistula restenosis, and to identify the new and current standard of care to improve outcomes for your patients. We're going to start with Dr. Andrew Holden. As I mentioned, he'll be speaking to us from Auckland, New Zealand, and the title of his presentation is The Impact AV Access Study Results Through 36 Months. Andrew?
Well, thanks very much, Bart, and it's a real pleasure to join this outstanding faculty. And as you've mentioned, I'm going to discuss the results of the Impact AV Access Study, and in particular, the longer-term outcomes through 36 months. Actually, when we look at the background evidence for long-term patency of AV access intervention, it's really a very small data set made up of small studies, only 8 published, single center by and large, and no independent adjudication. And the 3-year patencies were not surprisingly pretty poor, averaging generally between 20 and 30%. Which is what we'd expect for long-term patencies in AV access intervention. And so the Impact AV Access IDE trial is the first large and independently adjudicated randomized controlled trial to present this long-term or 3-year data. Now, many of you will know that this trial was a prospective global multi-center randomized trial comparing the Impact paclitaxel drug-coated balloon to plain balloon angioplasty for de novo or restenotic lesions in the upper limb AV access circuit. There were 330 patients enrolled, mainly in the United States and Japan, but also in New Zealand, and they were randomized on a 1-to-1 basis. The key endpoints were a safety endpoint, which was serious adverse events through 30 days post-index procedure, and importantly, a primary effectiveness endpoint, which is target lesion primary patency through 6 months, defined as freedom from clinically driven target lesion revascularization or access circuit thrombosis through 6 months. Now, interestingly, we measured the 6 months plus a 30-day window, so it actually was measured to 210 days, and we might discuss that a little bit later. Now, if we look at the long-term follow-up, I should point out that patients initially were consented to follow up to 24 months. Extension to 5 years was then undertaken, particularly because of the concerns at the time of paclitaxel. So not surprisingly, in both arms of the trial, there were patients who declined consent or withdrew, but we still got a very reasonable number of patients in both arms of the trial who agreed to participate in the long-term follow-up. As we've known, these patients were very well matched in both the trial arm, the DCB arm, and the control arm in terms of background demographics. In both arms, 70% of the lesions were restenotic. And the distribution of lesions in terms of location was very much the same, with most of the lesions being at the anastomosis, the venous outflow, and the cephalic arch. And this is the primary endpoint data published in the New England Journal of Medicine, where drug-coated balloon angioplasty was clearly superior to plain balloon angioplasty in terms of patency at 6 months. You can see the separation of the Kaplan-Meier curves here, not only for target lesion primary patency, but also for entire access circuit primary patency. And at 210 days, we had an outstanding primary target lesion patency of 81.4%. So that was very pleasing, but perhaps even more pleasing and certainly surprising is we've seen a durable patency advantage for the DCB over the plain balloon at 24 months. This was presented in 2021. And also the entire access circuit patency was significantly better. We really didn't expect to see such a persistent patency advantage. And now we can look at the 36-month patencies. And you'll recall the patencies of small studies were in the order of around 20%. So to get a target lesion primary patency of 43% at 3 years is really outstanding. And to have this clearly statistically significant separation of patency above the plain balloon arm. Another way to look at this is what's the number for patients randomized to the DCB arm, how many re-interventions did they experience to maintain patency compared to the plain balloon? And if you were randomized to the DCB arm, you could expect a 21.3% reduction in the number of interventions required to maintain patency. And that's a very meaningful finding for patients whose quality of life is certainly challenged. Now we can see, again, surprisingly, although the overall numbers are not high, there is a significant patency advantage for the entire access circuit compared to standard percutaneous angioplasty, with a 20.7% reduction in interventions people randomized to the DCB arm. What about access circuit thrombosis? This is really a horrific complication. We know that it's the commonest cause of access loss. We know it's a very expensive thing to correct because these patients often have to be placed on temporary central lines or permanent central lines and undergo expensive thrombectomy procedures. We've learned that actually, if you look at the patency after a thrombosed access circuit, it's very poor, 10 to 25% of patent through 12 months. And unfortunately, we know that the occurrence of access circuit thrombosis harbors a very poor outcome in terms of all-cause mortality. We've been watching access circuit thrombosis and noticed even early on a difference between the two treatment arms favoring the DCB. But now at 36 months, we can see it's certainly reached statistical significance, well over twice the incidence of access circuit thrombosis if you were treated by a plain balloon. And it's such a catastrophic complication that I think this is worth noting. I mentioned we extended the trial out to 5 years, and while I think the rest of the world agrees that the paclitaxel mortality controversy is largely something in the past and due to trial design, it's very pleasing to see out to 3 years that there's absolutely no evidence of a mortality risk with the DCB. Actually, its all-cause mortality is a little lower than the plain balloon arm and well below what we know for expected mortality of hemodialysis patients in the US at 3 years. Well, we do have 2 large prospective randomized controlled trials looking at DCB and AV access, the IMPACT AV access IDE I've just been through, and the Lutonix AV IDE that you can see here on the right. And while at different time points there was a patency advantage in the Lutonix trial for the DCB, it missed its primary endpoint. If you look at, first of all, the Lutonix Kaplan-Meier curve and consider what is the time that it takes for half the patients in each arm of the trial to lose their patency, you can see there was a 2.5-month extension in the time it took to lose patency if you were in the DCB arm. But in the IMPACT AV access trial, this was a very significant 14.7 months it took to lose primary patency if you were randomized to the DCB arm. A striking difference between these 2 outcomes. And you can see now that we have the 3-year data on the left-hand side, and outstanding figures, as you can see. So the outcomes through 6 months in the study, it's the only randomized pivotal trial to demonstrate consistent and sustained clinical benefit through 36 months. The patients with end-stage renal disease randomized to the DCB had a 14.7-month longer period before they lost patency. Now, we've now seen that access circuit thrombosis was over twice as high an incidence in the PTA arm. There's no evidence of a mortality risk with paclitaxel DCB in this trial. And these durable results suggest the use of paclitaxel-coated AV access balloon as a standard of care for AV fistula maintenance. Now, just before I hand back to Bart, I was asked to just perhaps comment on another negative trial. And as I mentioned, the Latonics trial wasn't essentially negative. It did miss its primary endpoint, but showed patency advantages at other time points. But this trial, the PAVE trial performed in the United Kingdom, used a different primary efficacy point, that is the time to end of primary patency. And this did not show a patency benefit, but there are significant differences in trials. This trial was really run by physicians and society with no angiographic or ultrasound core lab adjudication. Importantly, there was no clinical event committee to assign whether reinterventions were clinically driven. That was really down to the interventionalists to decide. There were significant differences in patient and clinical parameters, but I think most importantly, the device was very different. The PAVE trial used the Latonics DCB, and it's important to note that all three of the positive DCBs in AV access with DCB versus plain balloon have used the impact balloon, which of course has a much higher dose of paclitaxel. So with that, Bart and the team, thanks very much for the opportunity to present this data.
Thank you so much, Andrew. That's a terrific presentation. It's difficult to get 36-month follow-up on any group of end-stage renal disease patients, and to your credit and your co-investigators and all of the sites, that was a terrific way to study the impact balloon and to collect this sort of data. The dramatic impact of the DCB in your study is noted. I do have a question, though. Certainly people are concerned about cost, at least here in the United States. And one of the questions that comes up has to do with de novo versus restenotic lesions, and whether one can preferentially use one strategy for one of those lesions or another for the other. Do you think that the drug-coated balloon has more of an impact on restenotic lesions, or should it just be used broadly across all lesions that we see in AV access fistulae?
Great question, Bart. I mean, just on the cost, I'll quickly add that there have been cost-effectiveness studies done now on this trial data in the US, in Europe, and in Korea and Japan, and showing that the added patency of the drug-coated balloon is highly cost-effective. But I get asked this question, where would you start with the DCB? And if we look at the data, while restenotic and de novo lesions responded better with a DCB than a plain balloon, the most powerful effect was in restenosis. And in terms of lesion location, it was at the anastomosis and in the cephalic arch. So if people are saying where would they start, I would say restenotic lesions and at those locations. But of course, based on the data, we use a DCB in all patients.
That's terrific, Andrew. Thank you so much for your presentation and response to that question. We're going to move ahead next with a presentation by Ari Kramer. I will reintroduce Ari. He's the Associate Professor of Surgery and Chairman of Vascular Access Department at Spartanburg Medical System in South Carolina. His topic is DCBs in my practice, impact of durable outcomes for my patients. Ari?
Thanks so much, Bart, and the rest of the faculty, and the wonderful invitation to be here to present with you. As you've mentioned, this is my talk, and I too was greatly influenced by this data. Primarily where I practice in South Carolina, I'm the primary access surgeon for a majority of the upstate of patients, and having this tool and technology available to our patients has certainly appropriately impacted our outcomes. Just to recap, I think it's super impressive to review and reflect on these very compelling numbers. A 21% reduction essentially in target lesion primary patency, and a 27.7% reduction in access thrombosis versus plain balloon angioplasty is compelling. So previous, when I would discuss access dysfunction, really we had, in my practice, three real opportunities to treat an outflow stenosis or an inflow stenosis. Essentially, plain balloon angioplasty, some form of a covered stent, depending on the territory involved, or a jump graft or a turn-down procedure or revision surgery of some kind. So briefly, I'd like to talk about the evolution of my algorithm. I think it's fair to say previously I was having a fair amount of mix between covered stent as well as plain balloon angioplasty prior to the use of the Impact AV DCB. And so I'd like to focus, what you can see is the total algorithm, and focus on the middle portion and the looker's right portion of my access planning. So as we look at the evolution, with the addition of the Impact AV DCB, I think we can see when we have a symptomatic stenosis and I look at venous anastomosis, or cannulation zone, plain balloon angioplasty has really been the bulwark of what we would use with plain balloon angioplasty. If we recur at less than 90 days, I'll use the DCB quite aggressively. When we look specifically again at that anastomosis and swing segment cephalic arch, I don't mind using the DCB as a primary pull, and I use it on every occasion for recurrence. And this has dramatically shifted our stent use, etc., and we've been able to extend our patency of AV access significantly. And I think that the cases that we're going to present will highlight specifically how we do so. So this would be a swing segment in AV access anastomosis stenosis, demonstrating the effectiveness of the Impact AV DCB. So what we have is a female 70 plus years old, and they have a fairly typical and representative past medical history of arthritis, congestive heart failure, diabetes, etc. The patient had a distal wrist fistula performed in the early part of June 2020, and the clinic had called us with concern about the inability to cannulate. What was identified was a high-grade stenosis of the swing segment by ultrasound in our office, and that prompted us to bring the patient to the angiogram, to an angiogram suite for us to perform the Impact procedure. So we had a distal wrist fistula, stenosis identified by ultrasound, and then ultimately again recurrent stenosis in 11 of 2021. When we look here, vessel prep is performed routinely with a 5x40 balloon at the anastomosis, and then treated with a demonstrated result. When we treat again, we get a repeat angiogram. We can see the inflow stenosis at the arterial anastomosis. We can follow that with a run demonstrating post-treatment, and then a completion treatment with this completed angiogram. So in September of 2020, after 14 months, the clinic returned the patient to us for a low transonic, which is typical in our area of the country, and identifying again a swing segment stenosis by ultrasound. We again elected to take the patient to the angiographic suite to perform a repeat procedure using a slightly larger balloon. And here we had a high-grade stenosis as identified on plain balloon angioplasty. After protracted balloon angioplasty, we applied the anti-restenotic therapy with a paclitaxel-coated balloon at the anastomosis, bridging the anastomosis to the target lesion. And on completion, we ended up with this target run, which demonstrated a very nice result. It's not the best image quality to demonstrate it. However, what is impressive is since that time, this patient has required no further treatment. Now, as we evaluate a recurrent cephalic arch stenosis, the effectiveness again is quite demonstrated. In this case, we had a 50-year-old male who had a typical past medical history, again, AFib, diabetes mellitus, hypertension, obstructive sleep apnea, and had had a failed transplant and was a non-smoker. Patient had had a long-term left upper extremity brachiocephalic fistula that was placed remotely in 2004, but had had multiple recurrent and accelerating interventions, which was frustrating to the patient and subsequently was frustrating to the clinic. The access had subsequently developed a pulsatility to it and had excessive bleeding post-cannulation. There was a recurrent cephalic arch stenosis identified, and we elected to treat with plain balloon angioplasty and again Impact AV DCB. And as we look at the total time frame of what we're about to talk about, 2004, we had the access placed, recurrent multiple interventions, which were accelerating in recurrence. cephalic arch stenosis identified in June of 2020, which is treated with DCB, and again, a delay in treatment between treatments, and then another repeat treatment in November of 2021. So here we are in June of 2020, identifying the cephalic arch and a high-grade outflow stenosis, and then subsequently treatment with a high-pressure balloon to get complete effacement of the lesion, subsequently treated with a paclitaxel IAV balloon, and upon completion of treatment, we see an excellent result on the viewer's right, and the patient did exceptionally well. Well, after 17 months, the patient had a return of complications at dialysis, and we repeated the same process of evaluation in our clinic. Pulsatile axis was identified. Ultrasound was suggestive of an outflow lesion at the cephalic arch. We returned the patient back to the angiographic suite, and we elected to perform a repeat procedure. So here we go. The patient was treated this time with an ultra-high pressure balloon, quite a bit longer at this particular time, and then recoded the lesion with an anti-restenotic therapy using the Impact AV DCB. Upon completion, we see a very nice result, and the patient has once again returned to dialysis and has been quite pleased without any evidence of recurrent stenosis or complications at dialysis. So as we recap the history of this patient, back in June 2020, 17 months, we performed the first DCB. This followed by a recurrent stenosis 17 months later, and then subsequently an excellent outcome, and the patient has returned to dialysis without any difficulty. So why does the paclitaxel-coated AV access balloon work? I think there's quite a bit of theory surrounding this. However, there's no question that paclitaxel has an outstanding history of being anti-restenotic. I think the dosing has quite a bit to do with it at 3.5 micrograms per millimeter squared. I think that having urea as the excipient allows an easy transfer from the solid phase delivery to the tissue itself, and preserving that sustained drug availability and prolonging the antiproliferative effect with a reservoir at therapeutic levels remaining 180 days, which correlates, I think, quite exceptionally with the data. And we're able to recognize that quite nicely in our patients in a clinical scenario, which makes this very nice to see something both on the podium and then in clinical practice marrying so well. So with that, I'd like to say thank you all.
Great. Thank you so much, Ari. It's great to see the 36-month data that Andrew presented brought down to the practical level. I do have a question for you. What do you do in the case of sort of secondary lesions? I know that I don't believe that was part of the Impact multi-center trial to include patients with secondary lesions, that is, remote lesions. But if you have a secondary lesion of significance that you feel is also implicated in AV fistula dysfunction, do you go ahead and pull a second drug-coated balloon? Do you use the same balloon that you used on the first lesion on the second? How do you manage that?
So in fairness, this is it is a little bit of a challenging question simply because of costing. But the reality is that if the lesion is felt to be significant enough, I certainly will use a second Impact AV DCB, particularly if I have long lesions that will escape the therapeutic window of the first balloon. I have really no problem overlapping to get the full benefit. It's certainly a much more curated case. It's not something I do routinely. I would like to say that more, and in fact I would say very plainly, I would more often than not default to a plain balloon angioplasty addressing all the inflow lesions, followed by a target lesion with the DCB, and I will use whatever's residual on that balloon to see what our result is, and if we have adequacy, I'll probably go ahead and let that move forward clinically to see where we are. If I don't see what I feel is an appropriate response, I'm going to get a little bit more aggressive and treat it as a second primary.
All right, and then for our final presentation, I'd like to reintroduce Terry Litchfield. Terry is not only the president of Access Solutions out of Wisconsin, but she has lived a life very close to dialysis access and end-stage renal disease. She'll tell you a bit about that in just a moment, and then explain the patient perspectives on drug-coated balloons for access dysfunction, should it be the standard of care. Terry?
Thank you, Dr. Dolmach. And I'm very excited and pleased to be here. So I appreciate being invited. I think it's really important that the patient perspective be included in every discussion. I was married to an ESRD veteran of 46 years. My husband, who passed away several years ago, was, again, an early dialysis patient in 1968. He had 37 permanent accesses. So I understand fully what it's like to be a part of a family with ESKD. And let me assure you, vascular access is the Achilles heel. Patient engagement is really important in any new device. And so I really want to make sure that everybody understands, what does that mean to dialysis patients? So I know that there are the realities of demographics of dialysis patients. They're old. They're not only on dialysis, they have other comorbid conditions. Unfortunately, they're predominantly minority and often have some of the issues related to economics and the elderly. Patient engagement is the patient being totally involved with their team. So their dialysis team, their interventional team. And really, it's very important that everyone be aware that there is treatment for this patient regularly outside of the dialysis center, especially things like vascular access care, which happens several times a year. Patient engagement is being able to ask questions about things that you're not familiar with, like drug-coated balloons. Most patients really don't understand the nuances of what procedures are being done when they're in a procedure room. And then patient engagement is not being afraid to ask questions. The only dumb question is the one you don't ask. So don't be afraid to ask and ask again until you understand. So I'd like the providers in the audience to understand one key concept, and that's, if you ask a patient, do you have any questions? Very often they will say, I have no questions. But the reality is they don't know what question to ask. So take the advantage and suggest questions they might want to ask. There are a lot of vascular access innovations here and now. Some of them, like percutaneous fistula creations, patients get excited about it because it means you can get a new fistula without open surgery. There are bioengineered vessels being developed, and there's continuing development of drug-eluting stents and balloons. And many patients have heard about the Wearable Artificial Kidney Project, and they're developing a unique vascular access for that, for internal use. And there are many, many more vascular access innovations in the pipeline. What are the patient needs for decision-making for access? And you understand, 3 times a week, a patient makes a decision consciously to go to dialysis. But I will tell you, when somebody asks, well, you have to go for an access intervention, very often the patients will push back and ask questions. And sometimes, as all of you know, a patient will not show up for a scheduled access intervention. The first thing is patients want a clear communication in a language they understand. For those of you who have patients for whom Spanish or other languages are their primary language, many of you do have staff who can translate, but I always encourage people to use the language lines that are available that will bring to the patient a communication in a language they understand. It's also important to be sensitive to the educational level and keep the education that you're doing with your patients at their level. And they want to know vascular access options with unbiased information. So if you are only able to offer a few things, it's not unbiased when you don't offer things that you yourself don't stock. We also want a mechanism and protocols that are specific to the individual patient. And that's really important. And then patient concerns, desires, and needs are really need to be considered. So talking with the patient about what the options are. All too often, a patient is given the option, singular, but discuss other options. And finally, just a reminder to everyone, patients are, from their perspective, the most important member of the care team. And patients and clinicians don't always have the same vascular access goals. What is important to patients, it may seem trivial at times to providers. Patients are worried about body image. So sometimes the multiple stenoses and needle injuries and the megafistulas really do impact patients' body image. Scarring, so multiple surgical accesses, is not something a patient really wants. Patients also tend to have fear of needles, which is never good for dialysis and permanent access, but it is a reality. And so to address that reality is really important. And I saved the most important one, the one we hear in all of our patient surveys: surgeries and interventions we would like to avoid at all costs. And it's really important to providers, and may not be as important to patients, are things like vein preservation, thrombosis, stenosis. We know once an access clots, it may signal the end of its life. It may not be able to be declotted after a particularly difficult thrombosis. But that doesn't really resonate well with patients. And again, quality of life should trump everything, keeping patients doing what they normally do, their day-to-day routine life. What do patients want with innovative devices like drug-coated balloons? First of all, they want a better quality of life through less impact, fewer surgeries, interventions, hassle-free access. And so quality of life for dialysis patients means me and my family doing the things that we normally do. COVID has actually stressed the importance of reducing the risk of infection by fewer hospital visits or any type of procedures being performed. We have seen in some of the recent data that dialysis patients have missed things like colonoscopies and mammograms and regular things like immunizations that they might need. And so it's really important that patients understand when a particular device might help them avoid additional procedures or surgeries. Improved clinical well-being is something they always want from innovative devices. And it's pretty simple in vascular access. When you have a good working vascular access, your adequacy on dialysis will be better. And the better your dialysis numbers, the better you will feel. And then something I always like to bring up is the cost of interventions to the patient. Because fewer interventions mean less out-of-pocket medical expenses. Anyone who has a health plan knows that you have copays. You also have parking fees when you drive to the hospital or the clinic. You may have to travel there with the price of gas. It's pretty high cost to get to the access center. And then the impact of family time, because family member needs to take off of work to drive the patient to have an access intervention. And I would say less stress. An innovation like the drug-coated balloon we've talked about today will really reduce the stress, because anytime a patient goes in for an intervention, as a family member and as a patient, you worry about, am I going to have a complication? Am I going to lose the access? Am I going to react poorly to the anesthesia? And worst case scenario for the real worry wart patients, am I going to die? Because patients want to live and live well. I have some patient-focused questions, and I actually have the answers on drug-coated balloons. For those of you that might be thinking, what should I be telling my patients about this important new technology? First of all, why is this technology important? And this is where you can talk about fewer interventions and fewer thrombosis or clotting. who will this device benefit? And so that's way you can tell your catheter patients that that's, if they have heard of a drug-coated balloon, that's not going to really help them. But for our AV fistula patients, absolutely. And then we've heard brilliantly today, did the data show fewer interventions or other advantages? And clearly and resonating today is at 3 years out, significant advantages by reduced interventions and clotting episodes. Will my overall cost of care go down? And if you can reduce an intervention, you're going to have a lesser cost of care. So your total cost of care, both for the patient and the health system, will go down. And who's eligible for the device? And as a physician, you can explain to the patient why the indications for use are appropriate to them and their access. It's about personalizing the access experience. And are there similar devices with the same or better outcomes? And I think we need to be transparent and be clear. There is no other drug-coated balloon on the market today with an indication for AV access that has the same or better outcomes. And then how can I make sure I have access to the latest technology for my access care? And this is where I tell patients, talk to your access providers, develop a relationship, talk to your nephrologist to ensure that you are getting access to the innovations that are developing each and every day in this exciting field. The data is clear that drug-coated balloons have advantages over plain balloons. The vascular access, and this is a patient perspective, so the words will be more simple than the presentations you've heard today. The access stays open longer, and that translates to fewer interventions per patient per year. And it improves quality of life and avoids a hospital or an access clinic visit each year. And every access intervention carries risk. Every risk impacts the patient and family if a complication occurs. And so I believe that on behalf of patients, drug-coated balloons should be part of the standard of care for vascular access maintenance. So thank you very much for allowing me to share the patient perspective of this exciting new technology. Thank you.
Great. Thank you so much, Terry, for your insight, your perspective, and from the patient's perspective. It's become so important to involve the patient in so many of these decisions, and that, of course, is part of what the new KDOQI guidelines stress as well. Let me ask you a question or two. We know that we want to include patients in the discussion before they start dialysis, when they start dialysis, and as they need interventions following the initiation of dialysis. What's the best way really to connect patients and make them become more, if you will, activists in their overall care? When does that start? How does that happen? Do you have some thoughts about how to really engage patients?
I really do have some thoughts. And in the early days of dialysis care, patients had to be their own advocates because in the early years, Medicare didn't cover and insurance didn't cover dialysis. So always encouraging patients to find their voice. Many patients have a difficult time finding their voice. And so suggesting that they join one of the patient organizations, like the American Association of Kidney Patients, or Dialysis Patient Citizens, or if they're a home patient, there's Home Dialyzers United. And it's these patient-friendly, patient-led, free of charge patient organizations that will either help them find their voice or teach them how to advocate for themselves. And so it's really very important from the beginning, before they start dialysis, to educate the patients on who their advocate sources are and how to be their own advocate. It's very important to continue education of the patient along the continuum of their kidney care. Pre-dialysis, especially around vascular access care, why you need a vascular access before you start dialysis and how to take care of it. And then extend the conversation when an a new access either needs intervention or an older access is showing signs of failing, make sure that you have easy to understand patient educational materials. And then finally, at the access site, at the hospital or at the office visit where a decision to have an intervention, or at the access center or ambulatory surgery center, make sure that you have patient educational materials to review with the patient before the procedure is performed, and then take home materials so that the family member caregiver has that information as well, to ensure that the access is taken care of outside of the dialysis center and the interventional suites.
But Terry, let me ask you something that's far afield from my practice as an interventional radiologist. I suspect you're going to have some insight on this. We say that there are lots of resources and we encourage patients to access them and to learn more about all of this, end-stage renal disease, dialysis options, and so forth. But do you think at some point we should just require patients to go through a basic course? I mean, this is complicated stuff, and a lot of doctors and APCs are just and nurses are very busy, and they don't really find the time, maybe they'd like to, but they don't have the time or find the time to educate the patients. Should there be some sort of a standardized training that patients who start on dialysis should undergo? I mean, recognizing that much of dialysis is paid for by us, by the government.
Absolutely. Absolutely. Required education. For example, when I married my husband, I took 2 weeks off of work. He was a home patient. I took 2 weeks off of work to be educated about dialysis care and access. I think that we would have better outcomes if patients at their level in their language went through education. And there's some interesting data that patients that do get this pre-dialysis CKD education through programs that are offered tend to have better outcomes, and they have a much higher permanent access rate. And so it really is. And another thing I'd like to add, right now in the dialysis centers, the COVID effects on staffing have really trickled down and hit the dialysis units hard. They are all very short-staffed. And so there is very little time when you are so short-staffed in a dialysis center to do true education.
And let me ask one more question about this. If you were to direct a patient to learn more about their dialysis access, hemodialysis access maintenance using drug-coated balloons, where would you direct them? If you said, here's 1 or 2 different sites you can go to with fairly straightforward explanations, this is pretty easy to understand, and you can see the benefit of drug-coated balloons, where would they go?
Well, right now, you really would be at the device makers' websites, but I'm going to ask Dr. Ari Kramer to reach out to the American Association of Kidney Patients. Dr. Kramer wrote a wonderful vascular access, understanding your vascular access brochure that has been downloaded thousands of times free of charge from the AAKP website. And so it's time for us to collectively provide that information to the patient organizations for easy download.
I agree that we're making great strides. Drug-coated balloons definitely have a role in taking better care of our end-stage renal disease patients on hemodialysis. Well, we have the small group of our panel together here, and I thought I'd ask a question about how the use of drug-coated balloons in AV fistulae has changed your practice. Are there any comments from you, Andrew or Ari?
Well, I think I mentioned, Bart, that based on the data, we've really switched to a primary DCB approach. I know that potentially upfront seems an expensive approach, but we've now got data to show that it's cost effective. So, you've got a treatment that's more efficacious and it's cost effective. I'm struggling to, try and understand why I wouldn't use it as a primary approach.
Ari, any comments there?
I really echo what Andrew's just said, particularly being hospital-based. It makes it super easy for me to say that we have a much more aggressive primary approach to using the Impact AV-DCB. On numerous occasions and other talks, I've explained the fact that this therapy in particular during COVID was a lifesaver for our patients and protected the patients from having recurrent complications that led to hospitalization by maintaining access patency. I stand by that. We've noted our intervention rates have significantly been reduced, and we're now concentrating on more challenging subset of patients where we would have been previously occupied doing a lot of revision and cleanup work on stent work, et cetera, infections. We've seen marked improvement in that arena. So yes, it's most certainly appropriately named Impact, and it has impacted our practice.
Great, thank you. But, let's talk just a moment about the cost effectiveness. Certainly, reducing the number of interventions that occur over time is an important thing for the patients, and it's overall better health care. And cost reduction in the overall system for providing that kind of better care has been documented for drug-coated balloons and other technologies for AV access. The issue gets to be for the individual provider who's working in, let's say, an outpatient center, where the cost of the balloon is quite substantial. Any progress on reimbursement or ways to justify for the individual center the broadened use of drug-coated balloons?
And why there should be some type of either add-on code or incremental payment. And those discussions, I understand, are being held at the level of CMS. And, one of the things that when we talk about cost, there's also a patient cost. Family members lost work and co-pays with the procedure. So when we really look at this, it's energizing to see the excitement at the managed plans and those who are participating in the new Kidney Care Choices model, which looks at the whole risk and payment for the kidney patient.
Terry, you mentioned, the patient impact, and this is something that really does resonate with me as well. A couple of things, that we presented the 3-year data. One was a reduction in the sort of catastrophic event of access circuit thrombosis. And the other was this reduction of the number of interventions required to maintain patency. How does reducing the number of interventions really resonate with patients, who are challenged with, managing so much in their lives around hemodialysis?
Well, I'm going to speak firsthand as a spouse. It really does impact the patient and the family. So any reduction in any type of intervention, patients want to avoid surgery, interventions, and in this post-COVID era, they want to avoid hospitals at all costs. And so when you can get them a treatment that keeps them out of interventional suites, that lets them get back to their normal lifestyle, that's what they want. What I hear most often is the comment, we want hassle-free access. And so that means fewer interventions. It also means more money in your pocket, fewer co-pays, fewer people having to take off work. One of the other things that we don't think about, and I look at Dr. Kramer, who's in South Carolina and services a lot of rural patients, the impact of recent gasoline prices. It's very expensive to drive mom or dad or a spouse 40 miles away to have an access procedure, which unfortunately happens usually more than once a year.
Andrew, let me ask you a question about the 36-month data. I know that about a third of the patients who were enrolled in Japan, and I also think there are a lot more radiocephalic fistulae in Japan than in other centers outside of Japan. Do you have any comments about the patient population, the findings in these different subsets, and if that mattered at all?
Yeah, thanks, Bart. I mean, I think it's important to acknowledge that the patient data and the patient demographics were quite different in this trial compared to the Lutonix trial. You remember was performed only in the US, and a much higher percentage of upper arm fistulae, as you pointed out. I think in the Japanese group, what we did see, interestingly, was a much higher incidence of radiocephalic fistulas. And as I mentioned before, we not only saw a differential better performance with the DCB at the AV anastomosis, But really interestingly, the smaller the vessels got, the better the DCB performed compared to plain angioplasty. So if you were dilating a 4 or 5 millimeter AV anastomosis, we know they do very poorly with plain balloons and restenose very aggressively. But we saw the most benefit in that group of patients. So I think we learned we should acknowledge that, there is a different cohort of patients in this trial, and we can extract some very useful information, particularly around small vessel anastomoses and the very powerful effect of DCB there.
Thanks. One other question about that, and I guess this is both for any of the panelists. If you use a DCB and you can prolong the time between interventions, let's say by 16 months, which is terrific, then the patient comes back with a similar looking lesion and you treat them again. At what point do you say you're going to keep on treating them with the DCB versus trying something else? I mean, is there a break point at 8 months or 12 months or 16 months? How do you decide ongoing DCB treatment is the way to go versus trying a surgical revision or a covered stent or something else?
Well, I'll take a pass at this one. I think what Terry had said resonates very strongly with me. Patients would prefer not to see me for open operative care. And if I can prevent complications of an open operative repair by using DCB, I'm perfectly willing to continue on, especially if I'm continuing to appreciate that same window of intervention-free therapy. There's, I think, a secondary mythology that the next operation you do will be better or equal to the one you've already got. And we've gone down that road before where we've done a revision and had worser outcomes than the primary treatment which we were rendering with balloon. So I think you have to measure that cautiously. I think you have to measure the morbidity and potential mortality that we have with every patient that we bring. And so if I can maintain a minimally invasive approach and get significant outcome improvements from standard therapies with intervention, I'll do that as long as I possibly can.
But let's say you've done a DCB and in that one patient, it lasted for 4 months. Would you do a DCB again for the same recurrent lesion or consider going to something else? So I'm trying to figure out if there's a break point where you say, well, we did it, and in this one patient, it didn't work as long as we had hoped. Would we treat that again with a larger DCB or move on to some other therapy? What do you think?
Well, for myself, most assuredly, I would try to be more aggressive with a balloon if I was able. I still maintain that all the therapies that are available to us are there for a reason. So understanding, for example, where the territory is, that would very much be dependent upon what therapy I would have as a fallback. If, for example, I was at the cephalic arch, which is quite prevalent in our population of patients, we have a predominance of upper arm fistula. So brachiocephalic fistula is quite common. If we got very aggressive at the arch and we failed at 4 months, I would aggressively re-DCB that with a larger balloon. And then if the patient failed or I ruptured that arch, I could certainly fall back and place covered stent as necessary, or we could revert to a turn down procedure, jump, etc. So I think in that setting, I think that's a perfectly legitimately reasonable algorithm that is patient-centered. If it's the arterial anastomosis, depending on where that is, at the wrist or the upper arm, I would again repeat that same algorithm. However, in this particular instance, I wouldn't be so aggressive that I would want to risk a rupture at the arterial anastomosis. I would repeat, and if we had a worse outcome than we would anticipate, and we didn't get the durable effect that we had been seeing as the baseline, and it was shrinking, certainly do an open revision at that time.
Andrew, any time point at which you might say, well, we better go with another DCB or go with a covered stent or surgery or something like that? Any thoughts?
Yeah, I think Ari summarized it very nicely. So at our multidisciplinary meeting, we not only look at the anatomy, we do look at the time to restenosis. So I think this is increasingly becoming an important point. And what we've seen almost always is a prolongation of the time to restenosis with the use of a DCB. If you've got, as you say, an 18-month time to restenosis, then why not use a DCB again and try and get another 18 months? These are lifelong patient commitments we make. But if you get the 4-month scenario you described, I'd be asking myself first question: was the vessel prepared properly at the time at the index procedure? And that's Ari's point about a larger balloon, and that would be my location, my strategy as well. I would look to prepare the vessel better the next time and add a DCB. I like the fact Ari pointed out the cephalic arch, because that's certainly a place, I think, where we do see a mechanical challenge, recoil, and a DCB won't overcome significant recoil. So as Ari mentioned, I think there is a place for covered stents in some locations, and the cephalic arch is particularly one where we should, if we are failing with the DCB, have a threshold to do that. But I think we basically take a very similar approach.
Thanks so much, Andrew. Terry, question: Do you think that patients understand that there's drug-coated balloon technology that can improve the length of time between interventions?
Honestly, most patients don't. They trust that the doctor performing their procedures understand the latest in technologies. What patients do understand very well is that going for what they often term a roto-rooter every 3 months is not acceptable. And so I think it's up to the treatment teams to explain at a patient level that there's a new technology, there's a new type of balloon that will help have them intervention free so that their access, and probably the most exciting thing is to really reduce the clotting or the thrombosis associated with their access, because a clotted access is an emergency and often will lead to the end of life for that access, which means surgery and a central venous catheter, which patients do know central venous catheters are bad.
What do you think, I'll ask the panel, are the next steps for drug-coated balloons in AV access? I mean, what haven't we answered? What's important to figure out, both on the patient side, on the practitioner side, on the technology side? Where do we go next?
I might have a first crack, and then I think one of the things is we need to make the technology more accessible. I mentioned, I've been proud of this trial. I've never been involved in a trial before that showed such a powerful treatment effect for the trial arm, in this case, a DCB, and then to be able to show it's highly cost effective. And yet for a whole lot of other complexities like distribution, like financial issues working in an outpatient setting, it's not available to a huge number of patients. If you look at market penetration of these technologies, many patients aren't getting the benefits of it. So I think on a patient basis, we've got some challenges there. And then the second thing, obviously, is we talked about DCB and access circuit. And, the next frontier is the central veins. And does DCB have a role there?
Well, great. I'd like to thank everybody on the panel so much for your contributions and presentations. I hope that those of you who are watching this webinar have learned a lot about drug-coated balloon technology in arteriovenous fistulae. We've learned a tremendous amount from 36-month data that Dr. Holden presented, real-life application of drug-coated balloon technology in AV access that Dr. Kramer presented, and certainly the patient perspective as Terry Lichfield has gone over. Thank you so much for attending.